ચાલો નિમિત સર, હવે આપણે સ્ટાર્ટ કરી શકીએ છીએ.
યસ મેમ.
તો હું સ્ટાર્ટ કરી દઉં છું ઇન્ટ્રોડક્શનથી. ગુડ આફ્ટરનૂન એવરીવન. હું જીલ શાહ
હું મનીષા ઉપાધ્યાય.
અને અમે SHSRCના બિહાફમાં આપ સૌનું સ્વાગત કરીએ છીએ આજના વેબિનાર સિરીઝ એપિસોડ 4માં હેલ્થ રીચના, જે છે રિસર્ચ, એજ્યુકેટ એન્ડ એડવાન્સમેન્ટ ઇન કમ્યુનિટી હેલ્થ. આપ સૌ જાણીએ છીએ કે આજના સમયમાં નોન કમ્યુનિકેબલ ડિસીઝ એ એક બહુ ઇમ્પોર્ટન્ટ પબ્લિક હેલ્થ કન્સર્ન છે. અને એમાં પણ ખાસ કરીને વાત કરીએ તો કેન્સર એ બહુ જ અત્યારે ઇમ્પોર્ટન્ટ છે, કારણ કે એની અવેરનેસ લોકોમાં બહુ જ ઓછી છે અને એના કારણે જ ઘણી બધી વાર જોવા મળ્યું છે કે અવેરનેસ ઓછી છે, એના કારણે લાસ્ટ સ્ટેજ સુધી ડિટેક્ટ નથી કરી શકતા અને એના લીધે જ મૃત્યુ દર બહુ જ વધારે છે. તો આ મુદ્દાને સંબોધવા માટે એક કમ્યુનિટી બેઝડ કેન્સર સ્ક્રીનિંગ કેમ્પેઇનની શરૂઆત થયેલી કલોલ અને ગાંધીનગર તાલુકામાં, જે અમુક ગામડાઓમાં. તો હું આજના જે આપણા સ્પીકર છે ડોક્ટર નિમિત, જે CDMO છે ગાંધીનગરના, એમને રિક્વેસ્ટ કરીશ કે તેઓ આપણને આના વિશે જણાવે. ઓવર ટુ યુ સર.
Good afternoon to all of you. First of all, I would like to brief myself. Basically, by profession, I am a gynecologist, Dr. Nimit Escobar, and I am working. My working place is at the SDH level of the district Anand. At the outset, I would like to deliver my vote of thanks to the Dr. Tagri sir and the entire team of the SHSRC for giving me this wonderful opportunity to provide my presentation, which is the most sensitive part, not only in the Gujarat but across the nation as well as the globally. So my topic is audible. No? It's audible. Excuse me, ma'am. It's audible. I'm audible, isn't it?
હા હા સર.
Yes, sir, you are audible.
So this is my topic. The topic is a little bit off bit, but it's very sensitive and very significant nowadays in the life, because way back it was the malignancy, this cancer part was ignored or either neglected part, because it's most of the symptoms are benign. It's not acutely suffered by the most of the clients. So the topic which has been given to me by the SHSRC is the population-based cancer screening campaign. Now, moving towards this population-based cancer screening, there is three components which I have covered in today's topic. First will be of the cancer itself, that is the cancer screening test. Then history of the cancer, which are the investigation that should be performed on a day by day on a basis. And secondly, what are the example or experiment by which at the rural part of the our institutes can perform, by which we can detect and diagnose this cancer, and we can have a proper treatment management in time. And lastly, the most significant nowadays is the HPV vaccine, which is also related to a cancer part. So all these three components I will shortly present in my 40-45 minutes presentation. Whatever the queries are there, please note down, and we can have a healthy discussion after my presentation is over. Now, moving towards this cancer cervix. The cancer cervix, you all are aware that it's a very significant, but nowadays we can discuss that is the cancer is the first cancer which is globally very critical is the breast cancer, second is the cervical cancer, and third is the oral cancer. Worldwide, the breast cancer and the lung cancer are life-threatening, as well as India, at our national, also faces the same cancer, but we also include the cervical cancer. Let me tell you, in India, cancer of the uterus is the third most common cancer, with an incidence rate of 18.3%, and is the second leading cause of death, with a mortality rate of 9.1% as per the Globacon 2020. So while moving towards the worldwide, cancer cervix is the fourth most common among the women globally, with an estimated of 6 lakh population. New cases has been registered in 2020. Out of that, 3 lakh 42,000 deaths were found. So more than 70% in developing countries still like India, we have the record of 70% cases being diagnosed in the stage 2 and 3. Now, what I would like to insist or what I would like to focus our participants that cervical cancer, this should be detected on the stage 2 or stage 3, which is very important. If the patient comes in the stage 1, if we diagnose it by different tools, then we can detect it and we can intermittent on the way and we can stop the progress of the stage from the stage 1 to 2 or 3. Let me uh, let me inform you all that we should have also kind attention for our younger group of the patients. We usually neglect our younger group of patients, those who are coming in our consulting chamber of the public hospitals, like different complaints like white discharge, irregular periods, that are all ignore symptoms, but these are also very crucial for diagnosis of the cervical cancer. Cervical cancer screening is a success story for the modern medicine and is a reduced mortality of cervical by 70% in developed countries. There are different tools available. If we do this screening by different tools on a proper way, on a timeline manner, then we can reduce this mortality by 70%. The same is not possible in developing countries because of poor resources, lack of awareness, and our socio-cultural restraints. Still, so many people, so many patients, clients, and the relatives are not ready for like pap smear or colposcopy. They have a wrong myths and the wrong beliefs, due to which this malignancy or cancer increases on the 70% of the developing countries. Screening helps to detect pre-invasive lesions or early stage of the cervical cancer that can be detected successfully. See, pre-invasive lesion is very important key feature by which we can stop this spread of the cancer to the cancer stage 2 or 3. Different methods are available at all level, either it's a private hospital or it's a public hospital. I can what I want to say, like if it is a public health, a primary health center or community health center, these methods can also be utilized properly by which we can detect the cervical cancer. First is the pap smear, that is the cytological smear. Then second is the visual inspection with acetic acid, which is routinely done by the colposcopic examination. And third, which is the occasionally or rarely done, that is the DNA testing of the human papilloma virus. Now, these three tools we are going to discuss on the first component, by which we can diagnose the cervical at this stage, and then we can have interpretation of the treatment. Now, brief summary of the pap smear. Pap smear can be routinely performed at the PHCs and the CHCs if the medical officers are present here in this webinar. I would like to bring you kind notice that pap smear is a cytology-based screening test which detects the cervical cancer. Usually, two samples should be taken from the transformation zone. Transformation zone can be defined from the endocervix to the ectocervix. From this, if two samples are taken, we can have authentic results and the results can be comparable. Methods of doing pap smear are two methods are there. First is the conventional and second is the liquid-based cytology. Now moving towards the conventional, the slide is usually prepared by the X-ray spatula or it can be endocervical brush. Mostly the fixative material or solution which is used is the ethyl alcohol 90%, 95%. And the second one is the liquid-based cytology where the inner medium is already liquid-based to collect and preserve the cervical cytology cells, and then it is sent to the laboratory. Nowadays, the laboratories are also getting strengthened. Every district hospitals might be coming soon. Will be getting the IPHL lab. So there will be a sports and hub like pattern will be there in which we can transport these samples to the integrated laboratory or the district laboratory. This is a short picture or diagrammatic representations of different devices which are used for the pap smear. We all are aware of it, but I will repeat it and have a reorientation. First one is the iron spatula, which is commonly used and it is available by the government supplies. Then second one is the cytobrush, that is the endocervical brush. Then third one is the broom, which is also commonly used for to collect the material from the cervical part. Then this is a complete kit is available, including 95% of ethyl alcohol. and last one is the full kit of the basic cytology component. Now, when we perform the pap smear, that is the cytological screening, they will be having the three results. Very obvious that every results will be having three or two. Either it's a positive or negative. So if it is negative, never mind it. Just re-screen of the patients every year with the cytology report, which is available easily with your institute. Now moving towards the ASCUS, that is the atypical squamous cell of undetermined, then uh, if it is positive, means if then immediate triage with HPV test should be done. Now, if the HPV test is negative, then go for the re-screening 1 to 3 years with cytology. And if it is positive, we should advise the patient for the BIA or the biopsy, that is the colposcopy examination. And in colposcopy examination, it can be performed at the CHCs or the district hospitals. Colposcopy or the pap smear needs a 1 day training, which would like to inform our participants that it is well organized by the GCRI, and after this code of conduct is over, you can apply for this training at the GCRI, where 1 day training is given by the our experts and requires only half-day session for VIA as well as for this pap smear. If lesion is cervical intraepithelial neoplasia, that is, if it is one, we screen the patient after 1 to 8 weeks with cytology. No need for any intervention urgently needed. If lesion is CIN2, that is cervical intramural 2 plus, and it satisfies the eligibility criteria, then we should advise for the ablative therapy and ablation with the cryotherapy or any of the thermal ablation. And follow-up should be done after 1 year with the again cytology reports. Now, if there is a CIN, that is cervical intraabdominal neoplasia 2 plus, and does not satisfy the eligibility criteria, for the ablative therapy, then excisional procedure for low-grade squamous cell intraabdominal neoplasia, large loop excision of transverse zone should be conducted. This is the one kind of surgery which is advised for the patients of those who doesn't meet the eligibility criteria. And this also patient needs a 1 year follow-up with the cytology investigation. If the lesion is suggestive of invasive cancer, further evaluation and management based on the stages should be done. So this patient should be referred to the tertiary care center for the therapeutic purpose or the further surgical reconstructive therapies. Now, this is another screening test in which if it is the VIA, that is the visual inspection after application of acetic acid. Here the table enumerates both the parameters in which the white lesions, or we can say with the lesion appears when there is a suspect of malignancy or if there is a test is negative. So first is the parameters of acetobite lesion. Second will be visual inspection of with the acid with acetic acid, that is if the patient if it is found positive or if the BI is negative. Now speed of appearance, it is very clear cut that appears rapidly and may last for only 1 minute, and it will disappears after 1 to 2 minutes. But in case of it, if it is negative, then the speed of appearance of white lesion is very late, but it disappears quickly before 1 minute. So this is a very huge difference you can say, while if it is a negative or positive. Color intensity, the lesion will be shiny and cloudy white, more dense, thick and opaque. It should not be mixed up with the mucus plugs. While if it is negative, there will be a pale dull white, less dense, thin, often translucent. Borders and demarcation, if it is well demarcated, it is regular, and it is raised from the surrounding epithelium of the lesion. While in case of the if the VI is negative, it's a patchy white with ill-defined and diffuse margin. Margin cannot be recognized easily in case of if the VI is negative. Now location is only restricted to the transformation zone mostly. Lesion close to or abutting the scamocollinar junction. In case of if it is VI is negative, distributed widely in the cervix, not restricted to the transformation zone. Here is a huge difference. And color, while moving towards the color, it is very white, uniformly white, while there is a intensity variations across the lesion. Now next we can see the images of the different types of the pathologies or what we found during the our physical examination. Like this first example is a polyp that should not be mixed up with the any lesion. It is a pakka case of uterine polyp where the VI is found negative. Second, here is the Nabatean cyst. It's not a tumor or it's not a any swelling or it's not a pathology, but it's a Nabatean cyst. And here it's only seeing the mucus plug. What I am trying to show from these slides or from these pictures that it should not be mixed up with the our previous slide of VI positives, that is of shiny cloudy white, more dense, thick and opaque. Moving towards the erosion ectopy, it will be appearance like this, red shiny, but it's not a malignancy. Squamous metaplasia, it's like a very dark chocolate spots on the periphery of the external walls. Simultaneously, if there is the trichomonas vaginalis infection to the couple or any of the our patients, then there is a strawberry red patchy spots will be seen on the suggestive of there is a trichomonas vaginalis infection. This is same as the side of the satellite infection. Here you can say the satellite infections are there. Here you can say columnar epithelium that is staining with the acetic acid, and here we can see the junction, faint acetobitonin seen at the stenocolon junction. This junction is very easily defined and recognized. Whenever you see the VIA test positive, what we discuss here, just remember this that what is a VI positive? Speed of appearance, color intensity, borders demarcation, location and color luminosity. Same can be detected on these images. Whenever the images VIR tests are positive, just see the circumference of the cervical part. You will see the tiny opacity white part that is of the suggestive of the squamous calcium junction. Second one is at the white opacity which is shining at the 11 o'clock position as well as 12 o'clock position. And third figure shows of the VIA positive on the 11 o'clock, 1 o'clock, 7 o'clock and the 4 o'clock. If this type of four opacity white Chinese opacity are seen, then it's a strong suggestive of the stemocolinar functions. Then when there is suspicions of the malignancy, dense white margins are seen. This is a suspicious growth are seen, which bleeds usually on touch. Patient usually complains when there is a if there is either they complain of the dyspareunia or during the sexual intercourse they have bleed on touch. So in the age of 25 years, if such type of symptoms are there, never ignore it. Just go for the examination. Just go for the pap smear or the VI. This is the suspicious of the malignancy like cauliflower growth. Kobe, yeah, flower like it will be growth can be seen in the case of the malignancy of NS grade 2 or grade 3. These images should be kept in mind. Typical this type of images will be seen in case of the when you do for the VI test. Now, third one is the tool which is very useful, that is a HPV DNA testing, that is human papilloma virus. This is also nowadays burning to our societies. More healthcare provided and the self sample is acceptable. See, human papilloma virus can get not only to the patients, but healthcare providers are also parallelly can be affected of this virus. This can be detected by the PCR-based HPV-DNA, which is recommended by the primary screening. Now, PCR-based test and MNR-based test. Both tests can be performed by the hybrid culture to the amplification of the signal, service type HR2 and CAD test. This is a microbiological test. These are validated in the microbiology lab. If it is not available in district hospital, you can refer for this test to your nearby tertiary care center like district hospitals or the GCRI. Now, cervical screening test. We are worried about the reports and tests. How sensitivity means टेस्ट कितना पक्का है. हमने टेस्ट तो रिपोर्ट सैंपल्स तो भेज दिया, पर उसके बाद आने के बाद हम सब डाउट होता है कि हाउ इट कैन बी परफॉर्म, व्हाट आर द सेंसिटिविटी स्पेसिफिक. सो दिस इज वेरी इंपॉर्टेंट. In pap smear, the sensitivity is average 70%, means we are from 62 to 70, and the specificity will be from 90 to 96%. Moving towards the colposcopic examination, which is done by visual inspection with acetic acid, 74 to 79% is the sensitivity, and and specificity will be 85 to 85.8%. And DNA testing, obvious, it's more near to 100%, that is 99% and 88%. Now, from this comparison table, we can have a smaller calculation towards our public institute. If the PHCs and the CHC medical officers or at the HWC, what I have seen some of the initiatives who are taking for the referring the patient to the nearby PHC, CHCs, the pap smear is more specific, means 96% the results are specified. By compared to the colposcopy, the specificity is 85%. Between these two tests, pap smear is easy to perform, no need for further training or the reorientation training is required. It can be performed daycare as parallel as this VI test can be performed. But the only drawback in the cytology that test here is that we have to wait for at least 2 3 days because mounting is being done in the laboratory. So that is the reason that we prefer the colposcopy that should be made available to SDH or the some of the CHCs which are identified at the taluka levels or the taluka general hospitals, and where both this pap smear and the cytological examination or the colposcopic examination should be performed. Now, Federation of Obstetric Gynec Society recommendations are there. When to start screening? There's so much dilemma when to do either 20 years or 30 years. So every patient who are around about 25 years of the age with a good resource setting, universally means 30 years. Age to end screening is just 65 years. So if patient comes between 25 to 30 years or 35, start or initiate this screening for the pap smear or the colposcopy. And at the 65 years, three consecutive laboratory cytology results are there, or two results. Then wait for the 10 years. No more tests should be repeated. It should be repeated after the 5 years. Tests with the screening intervals. Primary testing every 5 years and limited resources twice in a lifetime. While screening after hysterectomy with removal of the cells, these patients often come to our consulting room. So it is not recommended when hysterectomy is done, but hysterectomy was done for the cancer or any other pre-malignant lesions. Then screening to be continued for the vault for every 5 years. For immunocompromised women, start at the age of the 25 years, that to be screened for more frequently duration. Between two screens that should not extend beyond 3 years, prefer to screen for the HPV test. Now, this is very important slide to our audience. That screening recommendation according to our resource setting. We are not having corporate hospitals; we are still public hospitals, and in the remote or the rural places, so many resources are limited. Still, they are required to be strengthened. So, if the low research, I would like to focus on the low research settings, means on the PHCs, on the CHCs, or some of the rural periphery tribal area of the XPH, where we can have affordable HPV testing at the IPHL lab or the medical college, or at least visual inspection with the acetic acid every 3 years from age group of 30 to 65. So, colposcopy is recommended in the low resource setting, while in the good resource setting, pap smear every 3 years or colposcopy, which is work feasible for the institute that can be performed. If both facilities are available, then it can be performed both. In our setup, we are having a setup of SDH level at the periphery part of the Anand district, and we perform both the pap smear as well as for the confirmation of the malignancy part for the colposcopy. Now, after primary screening from the BIA or FQDN, there are some results will be there, inferences will be there, from which we can move the patients what the treatment should be required. Now, if this VI rays colposcopy finding is at presently forget about the HPV testing. Just remember about the colposcopy, which is very important significant for our periphery PHC CHs. If VIA is negative, advise or request the patient for rescreening every 3 years. So we never miss any preoccupied lesions or the malignant part. But obviously, if the VIA is positive, then lesion is suitable for the ablation therapy, which is the criteria may fall in the cryotherapy or any of the thermal ablation therapy. And after this therapy, this therapy is usually given at the medical college, and if it is or the district hospitals, after this therapy is over, the patient is advised for follow-up after 1 year with VIA. If lesion is not suitable for ablation, means it's touchy on blade, profuse lesion, not able to identify the margin, diffuse margins, eroded margins, then in such cases, biopsy is advisable, excision procedure is advisable, and in this, cervical intraabdominal should be done, suspected cancer, and after that, go for the surgery and then follow after 1 year. So, if the patient reaches to this stage, we have to identify before this lesion at the pre-lesion. So, we can have some chemotherapy and we can prevent the patient from the surgeries also. Now, if the patient comes in the last stage, that is stage 3, that is the suspected cancer, go for the full evaluation as well as for the biopsy concept and go for the Pakka case of a cancer management. So VIA should be kept in mind to all our medical friends, all the paramedical friends, and consider between the negative and positive. If these are found, then take appropriate and adequate measures in time, so we can prevent further proliferation. If the HPV testing facility is possible in your district or in the city level, then if it is negative, perform 5 to 10 years, and if it is positive, go again. The therapy will be same, ablation therapy or the excisional procedure. And remember one thing: our patients do these therapies, but never come for the follow-up after 1 year. They will come after 2 or 3 years, whenever the symptom arises. So just keep a radar system, just keep a repo system with the patients, and request to follow at least for the 1 year. Now my first component is over. I would like to say one of the example which will have the motivation or inspiration to other districts and other institutes or other institutes where we can detect the malignancy at the first level and we can have the curative treatment at the further tertiary care center. In our SDH, we combined use of the four schemes of the government of India and the government of Gujarat. Of course, we are thankful to the state government as the national government for this all the four schemes. That is, one is the non-communicable disease, then day care chemotherapy, that is BCC, then of course the Ayushman Bharat scheme, and last is the telemedicine program. All these schemes were implemented in our obstetric and gynecology department of Betla. We tracked the patient and patient was successfully treated and finally the patient was discharged. Our aim for this is to address the rising needs of the carcinoma diagnosis and treatment. Nowadays the carcinoma is rising, so diagnosis should be made early and the prompt and adequate treatment should be given. The different objectives which our team focused was that to cater the targeted population who are the victims, get efficient pre and post surgical supports, and follow up to the patient died with the squamous cell carcinoma. So always have an objective. Always when you start run your the beginning of the month, make a schedule to target the population. There, make a schedule with the district peoples that this of the villages of the taluka we like to screen. If these people are screened at their appropriate time, then we can prevent the cancer moving towards the metastasis. Strength, the strengthening for the injuries in the hospital, it become possible to identify the patient of the carcinoma. The one of the patient came with the similar symptoms like white discharge and the bleeding irregularities and all that complaints which the patient routinely come in our OPD basis in our consulting room. But for unfortunate, the patient first visited to the private hospital. The trust-based hospital is a very renowned hospital. I will not name the hospital, but the patient went to that private hospital. The patient was heavily disappointed from the private hospital, and someone from the nearby patient was informed that go to the government hospital, which is situated in our Anand district, and take their observations, take their recommendations. So now days are gone where the previously the private hospitals, corporate hospitals are preferred by most of the patients. Now patients have started preferring the government setups. Their belief system has also started. This is a very good thing for the government side. After the confirmation report of the biopsy, patient was explained for the surgery, that is for the radical hysterectomy. Again, the patient was facing the issues of affordability. So our team implemented the white card should be there, and patient was have the benefit of all the health government. Finally, patient was recommended and radical hysterectomy was done. Parallelly, patient was shifted to nearby medical college for the chemotherapy. In this component, I would like to inform you all the participants, my dear friends, that e-Sanjeevani telemedicine, I would like to request all, please take help of e-Sanjeevani telemedicine of Government of Gujarat and the Government of India portal, which is very useful for our team, my doctors, even my medical officers. They constantly were in touch by through this portal to the oncology department and the experts of the oncology of the GCRA team, Ahmedabad, and we are fully thankful to the GCI team for supporting our medical officers and our specialists for treating this patient through e-Sanjeevani telemedicine. Of course, there are always challenges and hurdles are there. So the same challenges which our team faced was the treatment of patient was diagnosis towards definite treatment that needs to be provided and affordable accessibility. Previously, there was a lack of medicine. Nowadays, it has been improved of chemotherapy at the SPH level. Lack of trained personnel who can deal with supra major surgeries. But now it's not like that. In the district hospital, actually, there are many consultants and expertise are there. Required equipment like laparoscopic or any other instrument which is required for the supra major surgeries. Now it's also day by day getting availability. Prolonged procedures and necessary documentation which also become hurdle, and connectivity issues. So these were the challenges, but one by one we tackle the each challenges. We come over these challenges, and then finally we have benefit to the patient. Due to our efforts of the doctor staff and positive outcome was there. Patient was have a radical hysterectomy successfully, and then chemotherapy was there, and then due to telemedicine, the patient was successfully treated for this critical condition. Now we are moving forward towards the IPHL lab also, but this is our way forward. Why I like to highlight to all the our medical friends or the district peoples that integrated public health laboratory, which is a newer initiative of government of India. It's a robust mechanism by which all PHCs, CHCs, technical person can send their samples to this integrated public health laboratory, and they will different types of 2,500 tests will be conducted in the departments, including histopatho, cytology, and biochemistry. So I would like to request all the our participants that start this initiative of IPHL lab, which will be very helpful for our citizens. This is the photographs, surgeon performing and DHR team of medical officer and staff doing conduct with the e-Sanjeevani portal, biopsy report. And finally, last component is the HPV vaccine for the cervical screening. Recommendation for the caution on prevention and management of cervical cancer will develop for the assessor of obstetrician, gynecological physician, and here the general practice. So, FOSSI is also recommended for the general practitioner or the medical officer to start this recommendation of the HPV vaccination. The recommendation include here should not be viewed as a being exclusive or other concept or as a covering all legitimate strategies. These suggestions made here are not meant to dictate how particular patients should be treated because they are neither set a standard of care nor do they guarantee particular results. But all there is a sure results are there for prevention of the malignancy state. Human papillomavirus has a two subtypes, low risk as well as the high risk. Now, moving towards this virus, there are 9 strains. The two strains are the have a low risk, that is the 6 and 11, which leads to condyloma and the laryngeal papilloma. While high risk 16, 18, 31, 33, 45, 52, 58 leads to a oncogenital potential. This leads to a in female cervical, vulvar or vaginal cancer. Even in the male, oral and anal cancers are there. So few of the parents or few of the patients come to us for these vaccines. We always recommended this vaccine not only to the girls of 9 to 16 years, 9 to 15 years, also to the boys between 9 to 50 years. So if any of the parents visit to adolescent clinic or any of this counseling center or any gynec OPDs, recommended both girls and boys for this vaccination. This is a vaccination schedule. 2 doses from 9 to 14 years, at least 6 months should be given. 3 doses if the girl or boy is more than 15 to 26 years, then it should be given at the first dose. After first dose, then give 1 to 2 months, then third one is after the 6 months. 3 doses for the older woman till 45 years. If patient is 45-year-old, then 3 doses are usually recommended. So keep in mind 2 doses for the 9 to 14, and if the girl or boy is between 15 to 26, recommended for the 0, 2 month and the 6 month vaccination. Now for the boys who are from between the 9 to 26 years, give 2 doses of vaccination from 9 to 14 years, that is at the 0 and 6 months, and from the 15 to 26 years, give 3 doses, that is 0 to 6 months. So boys and girls both can be administered these HPV vaccines. HPV vaccines which are available in India, that is bivalent, quadrivalent, nonavalent. But what I would like to suggest is that is of the nonavalent, that is of the that contain 9 variants of the subtypes of the virus of the this HPV. So it is recommended. It is, but now it's very costly. It's costing around about 9,000 rupees. It's very costly. So if there is a finance related matter is there, then we can also recommend it for the bivalent or quadrivalent. Vaccine safety. Now, always there is a vaccine safety or vaccine related consequences are there. So there is no safety issues are there. Vaccine safety is not identified any safety concerns. All male, females, as usual, they will get injections and reactions like pain, redness, and swelling, and other mild effects like headache, dizziness, nausea will be there. All adverse events, all or any side effects that follow adverse are generally mild and after short duration they will disappear. For administration interchangeability, as per license indication, specific HPV vaccine can be administered concomitantly with the other vaccines like diphtheria, tetanus, and pertussis. So some of the parents ask us that we can give this with other vaccines if it has been given. There is no harm, no issues. You can proceed, you can advise them. Efforts should be made to administer the same vaccine for all doses when using a multi-dose study. However, if the vaccine used for the prior dose is unknown or unavailable, any HPV vaccine to complete the recommended is scheduled. Primary and secondary target groups. WHO recommended primary target population for all HPV vaccine girl is between from 9 to 14 years before they become sexually active. So 80% of coverage to all girls to reduce the risk of HPV vaccines as like as for the boys. Now vaccination of the secondary target population are females those age more than 15 years or boys or whoever sex with the men is recommended only if this is feasible and affordable, but does not divert the resources from the vaccination of the primary target population. Special situation, it is not recommended for use in pregnancy if the pregnancy is already confirmed. If the patient is couple is conceived, then it is not recommended. But if the patient conceives after the first dose, then it is advisable to give after the pregnancy is over. Concurrently, vaccination during pregnancy, there is no need for the medical termination of pregnancy. If already pregnancy and vaccination done, then if patient asks for them to be, then counsel them, there is no need for the termination of the pregnancy is required. Lactating woman can also be administered HPV vaccine. This should be kept in mind for all the medical officers or the gynecologists who are present in this webinar. All those patients, there is a Supreme Court guideline is also there. Those victims or the survivors of the sexual assault comes to your hospital in emergency routine basis for examination. Always advise them for the HPV vaccination. And if possible, from your side, from your institute, give the first dose of the HPV vaccine also. Because we are not sure for the window periods or for the samples when it will comes. Women with abnormal PEP or positive lesions can be vaccinated if they desire. However, they should be counseled that it is not a therapeutic vaccine, will not treat existing, but it only reduces the efficacy. HPV vaccination is a primary prevention intervention and does not eliminate the need for screening. Since the existing vaccine do not protect against all high-risk HPV vaccine. So this should be counseled properly and adequately to our clients. This was the specimen which was removed in the radical Vadan cystectomy. Here you can clearly see the lymph nodes, that is the lymphadenopathy was seen. So peripheral metastasis was not there, but it was the metastasis in the lymphatic tissues were involved. That's why the growth was seen. Obvious growth are seen. Uterus part, fallopian tubes, and the cervical part. So it was totally removed, and there was no other growth was found in any other organs. Now, I would like to just make a small video of this cancer orientation. So that's all from my side. Thank you all the participants and specifically to, Dr. Kadri sir and the entire team of the SHSRC for giving me this wonderful opportunity to provide my population-based screening of the cancer part. This is a very crucial and important topic for all of us, and we should have a strong efficacy for the HPV vaccine when the patient comes in our OPD, which is recommended by the WHO also. So, if any queries or any questions are there, uh, please be free. And any questions are there from any audience or participants? Otherwise, it's over from my side, and we can close this webinar. Yes, madam.
Thank you so much, sir, and thank you all the participants.
Thank you. We are closing this webinar. Thank you all of you.
Thank you so much, sir. Episode.